Okay, good morning. It's so nice to see more and more people in the audience. So I would welcome those that are online. We'll always have coffee for you and a smile. So please, if you can make it, we would really appreciate it in person. But of course, the virtual option is always a nice convenience. So before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. And I'm just going to put in a plug that last week we did celebrate Orange Shirt Day. And hopefully, if you've had a chance to open up our bi-monthly newsletter, we have a number of faculty members that are doing amazing research in Indigenous health and have formed amazing connections. So I hope you get a chance to read about it. Really excited. We have somebody making a road trip today. Dr. Nisha Bakshi. She is a general internist practicing at the Royal Alec Hospital since 2011. She is from the US, but we don't hold that against her. And she's done medical school in internal medicine in Philadelphia. She currently serves as divisional lead for GIM at the Royal Alec, which is a very busy job these days, as well as site director for medical education. She also has an outpatient practice in Sherwood Park and focuses on long COVID, on chronic fatigue and chronic illness. And this is a massive challenge. And I think patients from that present to various subspecialties as well as general internal medicine. So we thought it would be great to get an overview from someone who has some experience in the area. So welcome, Nisha.
Thank you. Thank you, everyone. Thanks for having me. I didn't do a road trip. I swam across the river. I don't know. There, is that better? Okay, perfect. Okay, so yeah, we're going to be tackling quite a big topic today, and it may go a little fast over some of the science, partially because I want to make sure that we have some time for discussion. And the other part is because, to be honest, the science is not exactly very robust. A lot of this is theoretical. A lot of this is still kind of in the works, and long COVID certainly has helped propel some of the research and funding for these topics, but right now, everything is still kind of hypotheses and theory. I appreciate Norman already did a land acknowledgement. So kind of today for our objectives, we are going to be reviewing central sensitization syndrome, CSS, POTS and ME/CFS. We're going to review some of the chronic management options that we can do in our outpatient practices and discuss the impact of these conditions on both individuals and then the medical system as a whole. So why this topic? In the last 15 to 20 years, we've definitely seen more and more recognition of these conditions as they present more and more in our outpatient practices. And we are developing a bit of an appreciation of the debilitating nature of these illnesses. Looking at general outpatient GIM referral patterns, that over 50% of new patient referrals have a constellation of symptoms that could fit into one of these three or all three of these diagnoses. The other reason I really wanted to focus on this was the stigma that's associated with CFS-ME, CSS, or POTS. We don't have any definitive biomarkers yet, and it often results in patient symptoms being classified as psychosomatic. I consider these all invisible illnesses, so patients may look well, and they may have been forced to have significant resilience to be able to keep up with their day-to-day activity. Most people still need to work, they still need to pay their bills, they still need to be a mom, dad, partner. And so they have to kind of force themselves to be well. This leads to stigmatization of they're not really suffering or even sometimes attention seeking. Often because their blood work all looks good, right? Their CRP is negative, their markers look fine. They're often not believed. And sometimes they can be seeking support from multiple different specialists. They may be referred out to many different areas, which can also be isolating and stigmatizing. And it sometimes leads patients to feel they need to seek alternative, maybe not evidence-based, and maybe unsafe treatment patterns or practitioners that are not evidence-informed because they need some sort of help. So we're going to start with CSS because CSS is kind of an umbrella term for many, many different symptoms and syndromes that we might see. It's kind of the umbrella for things like fibromyalgia, chronic pain, sleep disorders, POTS, restless leg, TMJ, all things that if you're an outpatient internist, you're seeing a lot of this in your clinic already. It all falls kind of under this idea of CSS. So what is CSS? Central sensitization was coined in 1989 after animal studies showed that spinal cord neurons become hyperexcitable over time after some sort of injury or trauma. This can be maintained, this hyperexcitability, without the trauma. So patient could recover from their acute illness, but the hyperexcitability or the kind of oversensitization of their neurons lasts long term, which can lead to widespread and migratory pain, as well as sensory hyperresponsiveness, so external auditory or visual stimuli. And often by the time the patient has presented to a practitioner, the acute illness or injury is resolved, and so we can't identify where this came from. The proposed pathophysiology for this is based in neuroplasticity, so the ability of the CNS to adapt over time. When peripheral nerves receive stimuli, the message received and the message is either amplified or inhibited. And in chronic pain syndromes, it has primed nerves to be more sensitive to stimulation, so their pain threshold might be lower. Instead of being protective responses, these pain signals become maladaptive changes and traditionally may increase your pain signal response as well. There's really not a lot of good epidemiological studies on CSS. A lot of it is self-reporting. And so in this one study that I was able to find, they showed a higher incidence in healthy women as compared to men. But again, it was attributed mostly to reporting. So women tend to report more symptoms that seem to be vaguer on the scale than men do. Most studies have not been able to identify any kind of causality with other risk factors such as smoking or alcohol or caffeine intake. So diagnostic features that may warrant you to start thinking about CSS in your patient is hyperalgesia, so everything hurts, allodynia, so scalp pain, hugging, patting might be very, very hurtful. One of the things that I see a lot in my clinic is patients say, I can't put the blanket on my feet, I can't put bed sheets on my feet, it just burns or hurts too much. And it's often accompanied with other symptoms that we see: fatigue, IBS, mood changes, and headaches. I really like this slide. I took this from the Cleveland Clinic, and I've left the link down there that'll be available afterwards. But it's kind of the idea of the pain, fatigue, and control cycle as it relates to the patient and their environment. So a patient has an illness, they might have been previously healthy, and now they're quite concerned, they're worried, so their family steps in and supports them. The patient does rest because they don't feel well, and so the family is, again, still supportive, still helping them. Patient seeks medical attention and family still continues to support. And now the patient is not able to get any answers. So their markers are okay. We can't figure out what's going on. They've heard the word psychosomatic 1 or 2 or 4 times. And they're trying to get frustrated and angry. Family is now trying to think about, how do we reestablish our roles? This is going on for longer than we expected. And over time, eventually the patient starts to become socially isolated, financially, spiritually depressed. They may not have the support now because the family is wondering, why is this going on for 6 months, a year, 2 years? And this must be in this patient's head. And this cycle continues. And this is very common when we see chronic illness of any kind, but particularly with these syndromes where we don't have a lot of answers. This is quite frequent. And I would say the other thing is that we don't have a lot of practitioners that are focusing on this. So it's often very isolating for patients to seek out the right care. One of the really important things in CSS management is CBT, but I would caution not to bring this up at your first appointment with the patient. I think it's really important to establish a relationship with the patient, but the patient, by the time they've seen you as the internist, as the neurologist, as the cardiologist, they have already heard, well, this must be in your head, you must have anxiety, let's work on stress reduction. And so if you bring up CBT in the first 30 minutes of your conversation with them, you've now lost them, you've lost the trust. However, after developing some relationship with them, CBT has actually been quite proven for CSS. And it's the idea of restructuring and reframing. And it's actually the idea of working on the neuroplasticity of the CNS. Can we help the neurons change the way they are sensitized? And so these are some statements that, we can work with our patients on. So people think I'm faking this versus people sometimes need help understanding medical issues. I can share what I know about chronic pain. But again, as I said at the bottom there, it's really important that their pain and symptoms are validated through this entire experience. Stress reduction. So again, I think this is really a funny thing to say in this world, but it is important that we talk to the patient about what is it that we can control, what are the the loci of control for you? Are there things that we can reduce your stress with? Can you get support for helping things around your house? Can you hire a cleaning lady to help you with certain chores? Things like that that might help alleviate some of the stress. Physical activity, I always recommend that initially in the diagnosis of CSS syndromes that if they are able to be referred to the CRIS clinic or they're able to go to physio or occupational therapy to help them recognize their limits and help them have some sort of guided program. I didn't go too detailed into the pharmacological. Usually it's very symptom dependent. These are things that we know from our fibromyalgia management, things like duloxetine, amitriptyline, NSAIDs, and trying to avoid opiates as much as possible. And then there's a number of non-pharmacological interventions that can help. Oftentimes the barrier to this might be finances and benefits for things like massage and acupuncture and counseling. But if there are ways to be able to do this through the public system, I strongly recommend that we are utilizing it for these patients. Okay, so that was a very quick overview of CSS, but wanted to just give a background because that helps lead into what we want to talk about with POTS and then CFS-ME. There's a lot of correlation and overlap in all these syndromes. So POTS, and most of you probably already know this, but we'll just quickly go through the definition. It's the orthostatic intolerance with excessive heart rate increase without hypotension during posture change, during upright posture. Higher prevalence in adolescent or young women. And in 2019, the global estimate was about 0.2% of the general population. However, that number has significantly increased as one of the main presentations of long COVID is associated dysautonomia. So this 0.2% is probably grossly underestimated. Typically, it's an acute presentation and there's often a trigger that we can identify, although idiopathic POTS does exist. But usually, majority of the cases, it's due to a viral syndrome of some sort of physical trauma, so MVA, concussion, spinal cord injury. Onset of menses can sometimes be the trigger for this, pregnancy, and then surgery. There are some patients that will have some recovery at the 18 to 24 months post-event, and in my practice, I see this kind of with patients who've had surgical causes for their POTS. Usually around the 2-year mark, things are improving. But majority of patients will report some level of chronic symptomatology with kind of a remitting and relapsing cycle. And as they kind of learn their triggers for their POTS episodes, they are able to extend the time where they have remitting cycles. So some common symptoms that you might hear: palpitations, chest pain. You may get dyspnea, fatigue. The instability and dizziness is a hallmark as well. In really severe cases, you may have syncope. I've had many patients pass out in my office. They'll usually pass out for 1 or 2 minutes, come to, and there's no kind of post-ictal or any kind of state afterwards, but very common. Poor exercise tolerance and circulation concerns. Really important to establish that symptoms worsen in an upright position and improves in recumbent positions. So to make the diagnosis, it's a clinical diagnosis. So orthostatic tachycardia greater than 30 beats per minute with change in position, usually greater than 3 months, and obviously absence of other cause of tachycardia. So typically by the time, if you're in an outpatient internal medicine clinic, most of the time the kind of obvious causes of tachycardia have been ruled out. Obviously if they're acutely ill with sepsis or infection, they're not showing up in their office. But you might want to look into hypothyroidism, PHEO, any kind of other metabolic causes prior to diagnosing POTS. Your physical examination is fairly straightforward: postural vital signs, cardiac examination, neurological examination. And you also want to assess for clinical features of hypermobile EDS in the right population. So if this is a very clear post-hysterectomy type of POTS, unlikely that it's going to be related to a brand new diagnosis of Ehlers-Danlos. But if it's a young lady, 18, 20 years old, there's a lot of correlation with EDS, and you want to make sure that you're assessing for that as well. Again, no specific biomarkers that are available for POTS at this time. So to tilt or not to tilt. So I have this poster in my office as well, and I show patients what a tilt table, because they always come in and nowadays people have already decided what their diagnosis is when they come in, and they've already have a list of tests that they want to order, and they are waiting for me to say the word tilt table. And they say, well, can I go for my tilt table? When can I go for a tilt table? Tilt table testing, as we know, can be done for POTS alone, or it can be done in a full autonomic lab, which includes the QSAR testing. And so here in Edmonton, the autonomic lab would be here. For tilt table testing, we can also, if we just went for POTS and not the full autonomic workup, Dr. Alan Jones at the High Center with Edmonton Cardiology also does. And I believe at the Nuns as well, there's capability for a tilt table. But POTS is still a clinical diagnosis. So I actually in my practice don't push forward with a tilt table test automatically. If I am pretty convinced of a diagnosis, I'm pretty convinced of POTS, I don't feel that the autonomic testing really adds very much. And it often puts patients into crashes. They often feel really horrible for 24, 48, 72 hours afterwards. And all I've done is confirm what I already knew. Not to mention it's 6, 8, 12 months wait time to get in. And often by that point, they're clinically much worse. They wanted to avoid treatment because they wanted to wait for the tilt test, table test, and now their functional and quality of life has gone down. The only other time that I will do it is if these patients are on disability and their insurance companies are giving us a hard time with the diagnosis. Sometimes they will require us to do a tilt table test, and then we'll do it. But typically most patients are usually okay with the explanation when I give them that I tell them it's going to make you feel worse and we already have a diagnosis. So there are different classifications of POTS. So there's hyperadrenergic POTS, which is kind of the extreme tachycardia and palpitations, migraines, nausea, vomiting. And this definitely you'll see a rise in their blood pressure when they stand up. Neuropathic POTS, so greater than 50% of people who have POTS have a neuropathic POTS, which is where they also develop lots of sweating. They'll have a very classical change of color. If you've got POTS patients in your office, sometimes you might see at the end of the appointment, their feet are bluish or purplish. And as soon as they stand up, things kind of get, as soon as they lie down, things get a little bit better. And then hypovolemic POTS. So this you may see actually the paradoxical thing where you'll see their blood pressure actually drop. We might need to give them fluids or give them medications to help improve their blood pressure. And all of these, I should actually comment that they all have decreased exercise tolerance due to the heart rate. So management, we all know this first part: drink more fluids, eat more salt, wear compression stockings. And we hope that this works. I would say this works a little bit at a time. Most people don't drink enough fluid, so getting them up to 3 liters is often a really big improvement. And they will start to notice that if they are having hypotensive episodes or if they're dizzy, this does help. I haven't really had any patients successfully wearing compression stockings all the time, so I'm not sure in real practice if this makes a whole lot of sense. But it is something that I will continue to write my consult letters and I continue to tell the patients. Graduated exercise therapy. So this is a bit controversial when you talk to various patients. So, you know, for pure POTS, graduated exercise therapy makes sense, right? So is the idea of having some level of time every day that you're going to do a certain activity and you slowly increase it. So I use walking for my patients. I say, okay, you're going to walk for 5 minutes every day for 5 to 6 days. The goal is to see that we can keep your heart rate between 90 and 110. And if you go above, you've done too much, you need to stop. The other goal that we're trying to see is that can you do it 5 days in a row without getting tired? If you can, we're now going to increase by 1 minute or 2 minutes. We're not going to increase by 30 minutes or 40 minutes. And I also tell them that walking can be challenging if there's a orthostatic component. So then that's where the recumbent bike might come into play. However, it's really important to see if there's a concomitant CFS picture here, a chronic fatigue picture, because graduated exercise therapy is actually contraindicated for patients with real CFS. It will make their post-exertional malaise even worse and therefore make their dysautonomia even worse. There's many now, since long COVID has come into our forefront, there's many POTS knowledgeable physiotherapy programs, including the Chris Clinic, as well as privately. So oftentimes if a patient is really struggling with how to manage their heart rate, I'll have them do 1 or 2 sessions with a physiotherapist just to get an understanding of how pacing actually works. And then pharmacotherapy. So I put this into kind of different categories that we might see for our POTS patients, depending on what they require. For heart rate control, so I often will start with propranolol. Although ivabradine has become kind of a medication that we're using a lot in dysautonomia secondary to long COVID, ivabradine is actually used for heart rate control for people with class 3 or 4 CHF. But there was a few cardiologists in the US that started using it early in kind of the pandemic for people with long COVID related dysautonomia. And what they found was that it reduced the amount of fatigue that's associated with beta blockers, and it also did not cause any hypotension. And so I've been using ivabradine quite a bit. Comes in BID dosing. The biggest challenge is coverage. So none of these patients have heart failure. So oftentimes we have to write letters or get special authorization for this. For some patients, we might use chronic IV saline infusions. Is hard in our current system, in our current healthcare system, to get this approved at the outpatient IV clinics on a regular basis. You might be able to get one infusion a week for a protracted time, 4 weeks, 6 weeks, 8 weeks. So I typically don't do this unless it's a really refractory case. I have a few patients that I took over from previous physicians that have IVADs implanted, that have PICC lines implanted for IV therapy at home. That's not a practice that I generally do at this point, primarily because I think part of it is a little bit of a placebo effect. It probably helps in the moment. It probably helps in that first kind of 24 hours that you got the saline infusion. And the second is to actually manage these lines. So lots of complications with sending somebody home with an IVAD or a PICC line. Home care in Edmonton will not follow these patients. The IV therapy will not follow these patients. So these patients are kind of left to their own devices trying to manage these lines, and it's ultimately not worth the risk. I have a few patients that will often come with me asking for IVIG. Really no evidence for IVIG in POTS at this point, and again, comes with some risk factors there. So associated complications and illnesses that we see with POTS. So often many of these patients will have an element of GI dysmotility, such as gastroparesis. And so depending on their clinical symptoms, I will order gastric emptying studies, or we may just start them on promotility agents. Have a number of patients that I share with the nutrition team at the Royal Alex, with Leah Gramlich and Jennifer Jin, who have concomitant POTS and severe gastroparesis that they need tube feeding. Also, a lot of these patients have CFS-ME based on their exercise intolerance, based on their inability to stand upright if their heart rate goes above 100. There's also a correlation with mast cell activation syndrome with these patients. So oftentimes it'll kind of first present as intolerance of medications, and then when you dig a little bit deeper, they have other symptoms such as idiopathic angioedema. They may have recurrent sore throats that may relate to mast cell activation. And as I mentioned, in our younger female population, we'll see concurrent EDS, which simply requires kind of a screening echocardiogram and genetics referral. And migraines are also quite associated with POTS. Okay, I rushed through those two because I want to spend the majority of my time on ME/CFS today. ME/CFS, and I think everybody can relate to this cartoon. This is how certainly I feel with all the referrals that I get. And ME/CFS is something that, has been around forever. And I was just commenting to Dr. Voth, who's here in the front, that years ago, one of Dr. Voth's last lectures at the Alex Grand Rounds was on CFS. So this is not a new diagnosis by any means, but certainly making a bit more news as of late. So ME stands for myalgic encephalomyelitis. CFS is chronic fatigue syndrome. And actually, when I was doing my research for this presentation, looking back at the history of ME/CFS, as early as the 1930s and 40s, this phenomenon was identified. And it was often identified after having big outbreaks of viruses throughout the world. The symptoms were varying depending on which report you would read, but one of the things that kept coming back to was post-exertional malaise. That seemed to be the kind of tying symptom all throughout history. Whenever these big pandemics or epidemics would happen, there would be this cluster of patients afterwards that couldn't function, that were very tired, that couldn't go back to work, that couldn't function in their life. And then things would die off for a little while, and then another infection or big event would happen. Ultimately, in 2011, there was a NIH study that was done that concluded that ME, which is what they were calling it in the UK, and CFS, which is what they were calling in the US, were actually the same thing. And so they decided to call it ME/CFS. Failure to identify a single causative agent for this diagnosis has often caused it to be under-recognized or classified as psychosomatic. In recent years, social media has actually been a really, really powerful tool for patients, allowing for a lot of organizing, a lot of advocacy work, research, fundraising, and increasing awareness of patterns of symptoms. And I know we all can kind of roll our eyes at Facebook groups that develop over certain things, but actually for ME/CFS has been very, very helpful. And it's actually shifted a lot of major institutions such as Cleveland Clinic such as Harvard, to focus a lot of their efforts on studying ME/CFS. So previously, it was strongly associated with a post-viral syndrome, usually EBV or mono. However, COVID has now surpassed that as a trigger of ME/CFS. There's a significant long COVID overlap. There's a lot of theories as to what's happening. I don't think we've even scratched the surface on why ME/CFS happens, but I've highlighted a few of the big ones that you will see in literature. So mitochondrial dysfunction, so lowered ATP production, impaired oxidative phosphorylation and causing mitochondrial damage. So you'll hear a lot of patients, well, I should say I hear a lot of patients coming in with bazillion supplements saying, these are all for mitochondrial support. So is that going to work for me? And we'll talk about supplements later, but mitochondrial support is kind of the trigger word as a buzzword right now in the ME/CFS community and the long COVID community. There's also chronic increased cytokine expression. So there's this idea of the NK cell expression has increased. And interestingly, I just came back from a long COVID conference in Quebec, where they identified that there's significant NK cell expression post-COVID, post-acute COVID as well. So there's certainly something happening with our cytokines in both COVID and in ME/CFS. The general idea is that there is cellular metabolism abnormalities. So there's an impaired ability to produce energy from usual fuel sources, such as oxygen, glucose, fatty acid. And there's also this idea of a genetic predisposition. So again, ME/CFS has only recently, in the last probably 15 to 20 years, been started to be accepted or regarded as a diagnosis. But when I talk to patients and they talk about their mom or their dad that had XYZ 20, 30 years ago after they had polio or after they had the measles or after they had something else, all very similar to what we would see right now in ME/CFS. There's also a possible link to fibromyalgia with elevated levels of BDNF. So BDNF is brain-derived neurotrophic factor. So we're going to talk a little bit about that, although again, the evidence is a little bit all over the place for this. So BDNF helps nerves grow and is vitally important for neuroplasticity and learning. We do know that BDNF levels increase with exercise, and exercise has been widely promoted to help increase these levels, which helps your cognition, your memory, your brain health. And so paradoxically, you would think that if there were increased BDNF levels in people with ME/CFS, they should feel great. They should feel cognitively really fantastic. So that's where the complexity comes in, and that's where we're not entirely sure what's happening there. But the idea, the thought is that the injury or trauma can potentiate BDNF to have actually a negative feedback. So they hyperexcite pain pathways, cause CSS, cause neuroinflammation. But again, there's at least 5 studies that show BDNF levels are low in ME/CFS, and there's 4 studies that show that it's high in ME/CFS. So ultimately, we don't actually know. I bring that up simply because, again, another trigger word that you might hear from your patient is neuroplasticity over and over and over again. And I think it's an interesting theory, and I think there's probably a lot of merit to studying this right now with ME/CFS, but the reality is we actually just don't know which way we're going. So, diagnosis for ME/CFS. So this comes from the Institute of Medicine in 2015, and essentially what it says is that there is a substantial reduction or impairment in your ability to engage in occupational, educational, social, personal activities for more than 6 months, as accompanied by fatigue. Now, we could all argue that that was all of us in 2021, 2022, going through COVID. Certainly was me. However, there's a couple other components that make this ME/CFS. So post-exertional malaise. Post-exertional malaise is that feeling flu-like, feeling really, really exhausted. It may be a flare-up of their symptoms, such as headache, such as dizziness. Usually it's an autonomic kind of flare that they feel. And what's really important to note is that PEM does not have to occur 20 minutes after the activity. It can occur 24 hours later. It can occur 48 hours later, 72 hours later. And sometimes patients won't have the language to say PEM or feeling unwell. They'll say crash. Well, I crashed 2 days later. I was in bed for 4 days. And that's a really big hallmark of ME/CFS. If they say they can go grocery shopping and go to the bank and make lunch for their kids and go to work, and they're a little tired at the end of the night, that's not PEM. PEM is inability to do anything for at least a few days to weeks to even months after an activity. And then they have to have one of 2 manifestations at least, cognitive impairment or orthostasis. The cognitive impairment is a bit tricky as well because there's no validated study right now that identifies what type of cognitive impairment that we're looking at in these patients. If you do our traditional cognitive screens, they generally score pretty well. So it has a little bit of an asterisk because it's a little bit of a, depending on the situation. I often look at what have you been able to do functionally? If you're an accountant, can you still be doing your accounting work? Are you making lots of mistakes? Those kinds of things. But that one's a little bit harder to diagnose. As I mentioned, so PEM is a hallmark. You might hear the words crash or flare. Oftentimes these can last from days to months. And then most patients with ME/CFS have some level of these other symptoms associated as well. So they may have MSK pain, migraines. You might hear a lot of swollen and tender lymph nodes. So when they get into a flare, they often comment on cervical lymphadenopathy or axillary lymphadenopathy. I saw a lot of this actually with just not only post-COVID, but I see a few vaccine injury patients as well, and they'll develop axillary or cervical lymphadenopathy that doesn't usually go away. It will reduce in size. They'll have the $1 million workup, including a PET scan to make sure there's no lymphoma. And generally, these are all reactive in nature. Patients with ME/CFS will often report overstimulation, so to sound, to crowds, to light, nausea, as well as sensitivity to smells, food, chemicals. All these are kind of MCAS features. Recurring sore throat is a very common feature as well for ME/CFS, and then POTS. So cognitive performance. So there was a couple studies that I wanted to highlight. So there was a cohort study in the UK that showed that the impairment was in the processing speed. So psychomotor speed, reduced memory, slowing of perceptual cognitive processes. And they actually removed depression from this as a confounder in this analysis. They also showed that impaired autonomic control of heart rate was found to be associated with reductions in basic processing speed. So if their dysautonomia was not controlled, if their heart rate variability was high, going from 60 at rest to 130 with a little bit of movement, that was also associated with cognitive slowing. And just recently this year, the Journal of Neuropsychology published a study using a test called the Continuous Performance Test. And it showed that ME/CFS patients had worse indicators of inattentiveness, vigilance, impulsivity, slow processing speed, and a higher likelihood of having ADHD. So I'm going to switch a little bit to how to see an ME/CFS patient. For those of you that do outpatient GIM, you probably have many of these similar kind of symptoms that pop up in your referral letters. And so over the years, I've kind of worked and slowly kind of come up with a process to not only make it easier for the patient, but also for myself to make sure that we've ruled out other things by the time they come to your appointment. So we often send a pre-appointment screening blood work. Majority of the time, this has already been done, right? The family physician has already done the ferritin and the thyroid, and it's not the ferritin, it's not the thyroid. But I'll go through the neck here and make sure that we've kind of ruled out all of those things. I always request a patient to bring a list of their symptoms and medications. Now, if you've seen ME/CFS patients, they don't really need this prompting. They usually will come with a binder of things and of symptoms. But I often will ask them to either bring it in before, or I also have I have a nurse in our clinic who will do a pre-screen phone call. That pre-screen phone call is also to help me kind of help manage the appointment. ME/CFS patients need to be listened to. They obviously have had a tough journey getting to this point, but we also need to make sure that the appointment has structure and that the appointment has a foundation to go to. So often the pre-screen helps me identify how am I going to structure this conversation. And then based on both the pre-screen phone call as well as the referral letter that I've been sent, we'll do other kind of, we'll at least send a referral in for other kinds of testing, such as a Holter, gastric emptying study. If there's significant memory impairment or other neurological symptoms, have they had an EMG, have they had a CT if it's appropriate. We'll also do age-appropriate malignancy screening because they're coming in with fatigue, as well as finding out if there's any other autoimmune disease risk factors. Appointment management. So the other things that I also do to help the patient in terms of their energy management. So if we talk about ME/CFS as this factor of how much energy do they have in their tank every day, going to an appointment is actually a lot of energy, right? So they have to get in the car, they have to put in the GPS where they have to go, they're going to a brand new place, a new surrounding. There might be a lot of people in that building, so it's going to be overstimulating for them. They're meeting a new physician and they want to get their story right. So there's a lot of factors that go in that may potentiate a crash for this patient just by coming to see the person that can help them. The initial consult is always in person. However, most of my follow-ups are done virtually, unless I need to do a physical examination or if they have POTS or some sort of orthostasis that I need to do vitals. I also, in my office, and I'm fortunate because this is my own clinic, I can make adjustments, but I have a reclining exam table, and I also have pillows on all of my exam tables to help give them some neck support if they need to lie down during their appointment. All of our rooms have the ability to dim our lights so that if the light is too stimulating, that we can take that out. I always ask them to bring a support person. Oftentimes with ME/CFS, it is very overwhelming. Sometimes if their processing speed is low, they don't catch everything that you're saying. So having a second person there, a second set of ears there to help remember the important information is really great. It also helps with supporting the family. So caregivers and families of patients with ME/CFS often don't understand what's going on for the patient. So it's helpful for the family to be there to understand, this is what my loved one is going through. This is how I can support them. I also create resources for patients. So similar to if you're on Connect Care as the after visit summary, I'm not on Connect Care, but I create a summary sheet for them. We also have a list of educational websites that we give to the patient so that they can do a lot of their self-managed care as well. And then I like to draw. So I draw everything out on a whiteboard and I show them what we're talking about. I have a diagram that I draw of the energy tank and how to manage their energy tank. And I find that that's very helpful for them to kind of visually understand what I'm saying, because again, it's a lot of information. So how do we manage ME/CFS? So one of the hallmarks for this is pacing and energy management. So identifying energy limits, triggers, crash severities. So if they know that going to the mailbox every day is going to cause them a crash, don't go to the mailbox every day, right? It's simple things like that that we help identify with the patient of what is it that's causing your symptoms to worsen. Oftentimes it's nothing, it can just happen. But usually there is some level of trigger or environmental thing that's happening that causes the crash. I ask the patient to record their crashes between their appointments. So the severity scale, which I'll show in the next slide, the duration of their crash, what were the triggers and what were the interventions that helped so that we can actually create a plan for them. What's really important is that I tell them that there is no cure for ME/CFS. And again, this comes with compassion, obviously. What I tell my patients is that we don't have a magic pill to fix this, but I'm committed to helping you manage this so that your quality of life improves. We take their quality of life score. We do a quality of life scoring at the first appointment, and we follow that through, not as part of any kind of study, but as a way to show them that, look, things have improved a little bit, or maybe they haven't, and we need to change course. But it gives a bit of the locus of control back to the patient. We move from a diagnostic heavy, from a cure heavy mindset to a rehabilitative and improving functional capacity focus. As I mentioned earlier, graduated exercise therapy is not recommended for ME/CFS. So telling your patient to get up and move a little bit more and exercise is not going to be the right thing to do. You're just going to put them into a crash. However, if you find a physiotherapist that understands ME/CFS and dysautonomia, it doesn't mean they can't move. It means that they can develop a program of saying, I can do a recumbent bike for 5 minutes and I don't crash. That is incredibly powerful for an ME/CFS patient who can develop some sort of routine. The other really important physical activity that I recommend to all ME/CFS patients is something called yin yoga. So it's a type of yoga that is floor-based. So it takes gravity out of the picture, takes orthostasis out of the picture, and it's stretching and breathing. So you hold various stretches for 3 to 5 minutes. The idea from the yoga perspective is to work on your breathing and mindfulness, but from a ME/CFS patient, it is improving blood flow to everything when they're stretching. It is giving them a sense of some sort of movement, and it is slowing them down. It's engaging the parasympathetics and hopefully removing that tachycardia as well. Counseling is really important. So finding a counselor that understands chronic illness that can help them accept and grieve the loss of their pre-ME/CFS life. The idea of, I want to go back to cross-country skiing and swimming and all of these things, those are great goals. But at some level, I always say in this season of your life, you have to accept that you can't do it. It doesn't mean never, but right now you can't. And then support groups. So there's many, many online and local clinics with support groups. Our clinic is going to be starting a support group for ME/CFS and long COVID in the new year. And the idea is really for patients to connect with one another so they feel less isolated, and support for families and caregivers as well. So We also use something called rate the week. And I would encourage everybody to kind of look at this as a way to manage expectations. This is what we do for patients. So 5 is your best week ever. Like you've had a really fantastic week, no crashes, you could do all of your activities, and you were actually able to add in some supplementary activities, go to the movies, have a date night, play basketball. 1 is fully crashed, bedridden, symptoms flared, couldn't do anything. We set a goal for 3. So 3 is where they're able to do all of their necessary ADLs without a flare or crash. They may not go to the movies, they may not go to a date night, but if we can actually average 3s for 8 to 12 weeks, so without a significant crash, that to me is stability. So we try to promote stability more than improvement, because stability is improvement in this case. If they can do that for 8 to 12 weeks, we start to brainstorm what extra activity can we add in. 10-minute walk, trip to the grocery store, phone call with a friend. So I asked them to bring in a calendar and rate their week and see how we do. And that also gives them an idea of, oh, actually things are getting a little bit better. It's not as horrible as I think it might be. I only put this up here for reference. It's probably very small, but the CDC has a fantastic section on ME/CFS. And so they have a before, during, and after visit kind of protocol. A lot of what I already talked about, have a list of your symptoms, have a support person that comes with you, make sure that you have a way to take notes or ask your provider if you can record them so that you can listen back. But on the CDC website, there's a significant amount of information for the patient for ME/CFS. This is what I do. I know it says long COVID clinic on there, but I use it for my ME/CFS patients as well. So mine's not quite as fancy as the after visit summary for Connect Care, but this is kind of what we give to patients after their appointment. So they will get a list of what medications we might have decided to start, why, other investigations. The non-medication interventions are things like physio, things like mental health, might be a YouTube video on guided meditation or something. And then the follow-up. So this is the tricky part. ME/CFS patients, when they come to see me or another internist that has some knowledge about it, they want to latch on. They want to see you every week. They want to call you all the time. They want your email address. They want your Instagram. They want everything. I know it because they've tried. And so recognizing that probably for the first time in a long time they felt heard, they feel safe. They want to kind of continue with this relationship. But obviously I cannot see everybody every week. And so what we do is I'm fortunate to have our clinic has support by the primary care network. So we have a nurse who will call them usually in 4 to 5 weeks after their initial appointment to check in on, if we've started any medications, how are they doing with those medications? How are they generally feeling? If there's something urgent, he'll let me know and we'll make adjustments. Otherwise, it's really just a reflective listening conversation. And then I will follow up with them generally in about 3 months. I'm really bad at my own boundary setting. So oftentimes I'll see them in 6 weeks and 8 weeks, and it's not good. But in reality, there should be kind of a regular 3, 6, 9 month, depending on the severity of some other medical symptoms. So if they're, having significant gastroparesis symptoms and malnourishment or significant tachycardia, I might see them sooner. And as I said, we offer them Zoom appointments as well, so we can avoid that extra trip to the clinic. So some of the management that I use in my clinic, so obviously, first of all, symptom management, so pain, migraine management, utilizing similar strategies to CSS, such as duloxetine, amitriptyline, NSAIDs. A lot of patients will ask me about low histamine diets. It's very anecdotal evidence. Low histamine diets are very difficult to follow. So it is gluten-free, dairy-free, sugar-free. And so I often tell patients, like, you can try it. I think it's going to be very hard to keep it going if you really want to be a purist about it. And usually if they're really insistent, I'll tell them to pick one thing. Generally, I'll say go gluten-free for a little while, see if it helps. But again, it's very anecdotal and primarily, I think, because it's very hard to maintain. Antihistamine support. So if they've got concurrent symptoms such as the lymphadenopathy or allergy type symptoms, I might put them on antihistamine such as Rupall or Blexten. We often look at sleep hygiene. So most of these patients, if not already, I will assess them for OSA. And if they require sleep aids, it's a little bit of a risk versus benefit. I know that, especially for my family medicine colleagues, there's a lot of reluctance to put patients on medications such as trazodone to help with sleep. But I look at it as a risk and benefit. If they're not even getting 4 hours of straight sleep, no matter what we do for them during the day is not going to help with their fatigue. And so it may require more frequent check-ins to make sure that there is no abuse of these medications, but I think it's not necessarily a battle worth fighting if there's bigger fish to fry here. Low-dose naltrexone. So I use low-dose naltrexone fairly frequently in my practice, and this started because of long COVID. So right now, all the reports are case reports and anecdotal reports. However, there's two big studies happening right now, one in Toronto, part of the CAN-COV study for long COVID. There's 10,000 patients enrolled in this study. It's being run by Angela Chung, who's an internist out there, as well as a study in the US looking at the effect of low-dose naltrexone, specifically for fatigue related to long COVID, although we should be able to extrapolate it to ME/CFS, as well as why it might be helping. So generally, the anecdotes show 3 to 5 milligrams daily seem to help with fatigue and pain. There are some theories as to why this is working. So LDN may be able to inhibit microglial activity, therefore reducing neuroinflammation, as well as improving cytokine function. In my practice, generally LDN is reasonably well tolerated. 5 milligrams, the main side effect is nausea. And so for most patients, we are starting at 0.5 milligrams and slowly working our way up over a 2 to 3 month period till we get to 5 milligrams. Some of the main side effects that we hear are nausea and vivid dreams. So depending on the time of day that you take this, it can be problematic with sleep. So generally I'm telling patients to take it in the morning. Obviously, you need to make sure that they're not on concurrent opiates or anything else that may negate the effect of naltrexone. It is only commercially available at 50 milligrams, so this does need to be compounded. Please don't ask your patient to cut into 1/10 of a pill. It's not going to work. And I think at this point, most of the Edmonton pharmacies know me, so if you try to prescribe this, they won't give you a hard time at this point. Stimulant and non-stimulant medication. So there was actually a study done that showed that there was a clinically significant effect with methylphenidate for these patients. So your stimulant therapy for cognitive dysfunction and brain fog. And with modafinil, interestingly, there was no significant effect. That said, I have a lot of patients who already are modafinil by the time they're seeing me. They're started by their family docs, and they seem to find a benefit. So I don't usually stop it if it's working well for them. But with the stimulant therapy, I am very cautious to start this, not because I don't think it will work, but because I actually think it could potentiate crashes if you're not discussing this thoroughly with your patient. With medications like Vyvanse or Concerta, your brain is going to tell you that you can focus and do all of the things, but your body might not be able to keep up. And so what ends up happening is these patients end up just like, they feel great. They just want to take on the day. They do all their taxes. They organize their entire house. And by 5 p.m., they've crashed so hard. They're like, well, this medication didn't work. And so if we're going to start stimulant therapy on these patients, it's critical that they understand the concept of pacing, that they set alarms in their phones to have a mandated break at 10 a.m., at 1 p.m., at 4 p.m. Even if they feel like they can do more, they need to stop. Other things that may come up. So there is anecdotal evidence for some vitamin supplementation with B12, C, magnesium. Coenzyme Q10 and NAC have been quoted to help with mitochondrial support. So again, it's that buzzword that's around right now, mitochondrial support. I generally caution my patients from over supplementing. Oftentimes by the time they've come to see me, they've probably gone to a naturopath already, and they may have a list of 10 or 15 different supplements. So we try to pare it down to what's absolutely needed, which often is usually not very much of anything. I'll tell them take vitamin D, but that's really about it from a vitamin perspective. And there's no evidence for IVIG, steroids, galantamine antivirals, antibiotics. There was a wave of, especially in my long COVID practice, of patients asking me about ivermectin. Obviously, no evidence for that. But I guess you can go to the US and get it very easily. So they would go anyways and get it, and nothing would happen, except they'd be tired from the traveling. So why is this all important? With increased recognition of long COVID and chronic fatigue, these clusters of illnesses are going to continue to surface in our patients. Fatigue makes up over 30% of the complaints to family physicians and makes up over 50% of the referrals to outpatient internal medicine. Ignoring these symptoms will only lead to more stigmatization, increased mental health, and potentially harmful outcomes. So increased substance use, maladaptive coping skills, and definitely increased ER visits. It also can increase depression, anxiety, and medical PTSD. Obviously, these patients will start to socially withdraw because of fatigue and triggers. It for sure causes losses of relationship, jobs, and finances. And certainly a big one that I think we need to recognize is the mistrust in the medical community, labeled as a troublesome patient or a functional or psychosomatic disorder. And this diagnosis bias stays with the patient as soon as it gets put in their chart one time in their ER or their Connect Care record. And therefore future are less likely to be believed for pain syndromes, which could lead to a delay in diagnosis and other potentially life-saving conditions. So system impacts. So I just took my clinic as a small little microcosm. So since January of last year, I've seen 400 new long COVID consults. Almost all of them meet the criteria for ME/CFS, which also means that I now have an inability to see non-ME/CFS patients. I can't see the diabetics and the hypertensives because these are taking up far more of my time. I've actually had to adapt this so the new consults are 90 minutes because it takes that much time to be able to parse through all their symptoms, do all of the education, and follow-ups of 45 minutes. So again, in a day, I can only see 3 new consults instead of 4 or 5 new consults of other patients. Of those 400 patients, 70% have required some level of disability form, income support, tax credit documentation. So this is a huge burden on so many different levels. It's a burden on the patient because if you've ever seen those forms, they're long, and it can sometimes take patients a month to even fill out their portion of this form. It takes me a very long time to fill these forms out, and if you see my book bag, like there's like 30 or 40 forms in there right now that I have to fill out. And also it's a big impact on the economy in general, right? So if we start to see a lot more people not being able to go to work and accessing social supports, at some point we're going to see this effect on a more larger scale. And of those that do apply for short-term, long-term, and age, they don't have the finances or benefits to allow them access to timely rehabilitative services and mental health supports. So there are limited supports for mental health through age. That's like very, very limited. And often the wait time is 6 to 12 months. For the Chris Clinic, depending on which route you go, it's also about 6 to 12 months. So by the time these patients are getting in, they're even more functionally behind. How it affects internal medicine in our system. So decreased outpatient GIM access due to inpatient demand. So we all know that right now we are being pulled inpatient even more because of high volumes, results in high wait times for these patients to be seen in the outpatient world. So what ends up happening is they come into ED and they are often told, well, your labs look fine. This must be stress or anxiety. Here's some clonazepam for a week. Go see your family doctor. Many of them don't even have a family doctor. Or they'll come in with POTS type symptoms and they'll get the troponin, they'll get the EKG, they might even see cardiology, and they'll say, well, nothing's wrong with you, your heart is fine. And medical gaslighting becomes the norm for these patients. So what needs to change? So I don't know about many of you in this room. I didn't learn about POTS when I was in medical school or residency. I learned it on the job. I didn't learn about dysautonomia very much, except for maybe spinal cord injury, and certainly did not even know what ME/CFS was, I think, until I watched some Netflix show like 5 years ago or 6 years ago. I didn't know what any of this was. We also need to recognize our own individual explicit and implicit biases when it comes to these patient presentations. I threw up a cartoon earlier in the presentation of how we all kind of run when we see this patient, but that's very real, and that very much happens. We do internal or external eye rolls when we see these referrals come to us, and that's okay too. These patients are not easy to manage. As I said, I've got 30 or 40 forms to fill out. I don't love it that I have to do that, but if we start to recognize that this is going to be a growing problem, hopefully there'll be more and more providers that can provide this care. And we also need to look at what we're documenting on their EMRs. If we start to write psychosomatic, it stays with them for life. Nothing ever changes that. What else needs to change? So we need to have better interdisciplinary care models. So patients who suffer from these are often in various stages of remitting and relapsing flares. They're considered they're often high needs patients and may require frequent visits. As I showed before, preemptively creating an appointment template for these patients gives them a trust-building relationship that you will not abandon them, but that they are more than their disease, so they do not need daily and weekly visits. That comes over time, but it's important. Models that include specialists with shared interests in these conditions so that patients feel as though they have a medical safety net. So I have, again, like I said, a few patients that I share with the nutrition clinic at the Alex. Those patients are really well cared for because they have an interdisciplinary model. And then in a beautiful unicorn world, we would have more funding for mental health and physio and occupational therapy. Finally, my own personal reflections. So patients with ME/CFS and medically unexplained symptoms can be complex and cause burnout amongst providers. I know certainly I'm very burned out from seeing all these patients. And it is okay, and in fact important to say this is a chronic illness. Our goal is to improve your functional capacity, and doing more tests may not change your diagnosis. Your diagnosis is a very real and valid one. I think patients want to have something reversible. And we do not like uncertainty. These diagnoses are fraught with uncertainty. But again, reaching a point of shared and realistic expectations with their patient can make it gratifying. You can reach me through many different channels if you were interested in some of the resources that I have. And I will open it up to some questions.
We actually have a translational researcher here who studies this, Dr. Jan Willem Cohen-Turver.
Well, our research focuses on the mitochondrial signature, although we see most patients with secondary forms of CFS-ME, meaning that we are focusing on patients with systemic sclerosis and vasculitis, long COVID, or patients who have breast implants or vaccination-induced CFS. And then Dr. Van Ede is actually here. She is the one who described it as the first author, that we found it as mitochondrial signature in patients with systemic sclerosis and CFS-ME. And this is not the systemic sclerosis patients at the end of their career, but in the very beginning of their disease. So already when they have Raynaud's phenomenon, we can predict who is going to have the CFS-ME with these mitochondrial signature. The other thing that I want to comment a little bit is the IVIG. You say there's no evidence. We are currently having some discussions and some money from a company to study this in more broad detail. And why? There has been clearly a disbalance in antibodies, autoantibodies to GPCR, by doing experiments in animals, we can show now that in fibromyalgia, in long COVID-induced CFS, and in ASIA, so in implant-related CFS, that you can transfer autoantibodies from the patients to the animals, where they are having then that neurological symptom as you see in the patients with CFS. So those are the things that are currently, at least, very important.
Yeah, and I think it's really exciting that we have that boundary, right? Because and maybe we'll have to have Dr. Cohen-Turver and his group present at a future grand rounds to bring us up to date. And then, of course, Dr. Demand has done work on the stigma piece of it, and he has a question, so I'm going to give it to him, or a comment.
Yeah, absolutely a brilliant presentation, and I think Easy said we need to find ways to address the stigma, because we now have reanalyzed, or we've restudied the initial cohort that we studied for stigma, and it's very powerfully predictive in terms of prognosis. People with high levels of stigma do poorly, and vice versa, at least in our cohort. My one question, though, is you alluded to the amount of time you spend per patient for new and follow-up visits. Do you think the system is supporting the care of these patients in terms of, like, so let's just make it simple and talk about fee schedules and things like that, or resource allocation?
That's a really great
So,
question.
Nisha, can I get you to come to the camera and maybe just restate or and then.
Yeah, so it was a comment and question from Dr. Demand. The comment was on, I think in the long COVID and high pop clinic study here, showing that the level of stigmatization definitely affects the prognosis or the outcomes for these patients. And the question was on the time that I'm spending with these patients. Is there something we can do, I think, on more system resource allocations? And yes, I think so. I think we've talked about this in our GIM groups, just in general for outpatient GIM. It is not worth it to do outpatient GIM, to be honest, if we're looking purely from a time to dollars perspective. And not to say that that's the only important thing, but it makes a difference when we're bringing in new young internists who are trying to figure out what to do with their career. We're not attracting them to outpatient. And when you have a population that's already difficult to manage, if you don't have the right supports in place, we're not going to get people out there. Yeah, I think we need to look at how we balance inpatient and outpatient remuneration.
Yeah. was just a brilliant presentation. And on behalf of the department, thank you so much for making the road trip and a brilliant presentation. Thank you.